Bangalore, FMIS from RGU HS Bangalore, DMCH from IGNOU Bangalore. Madam has been practicing since 20 years and has special interest in advanced laparoscopic and hysteroscopic surgeries. Dr. Arthi is EC member BSOG 2326, Secretary Urogynec KSOGA 2527, Life member BSOG IMA FOXY and IIG. With this brief introduction, I welcome Dr. Arthi Sridhara once again, and over to Madam.
Yeah. Thank you, Dr. Prashant. Thank you for your kind words. And today we will be discussing about the most common topic, that is the postpartum hemorrhage. Though it is a common topic, this is one of the nightmare for every obstetrician. So, but over the years, we have been able to manage postpartum hemorrhage with a lot of medications which have been coming up with which is actually reducing the maternal morbidity and mortality rates. So PPH is a condition which is very life-threatening for any obstetrician and even for the patient. But over the years, we have been able to manage it very well. So what is PPH? It is a loss of at least 500 ml blood following vaginal delivery or 1000 ml blood following C-section. It's a common condition and can occur in, just a second. So it is common and can occur even in women who are not at risk. It's the leading cause of maternal mortality in low-income countries and the primary cause of nearly 1/4 of all maternal deaths globally. Postpartum hemorrhage, it's unfortunate yet common. So maternal mortality is the leading cause of this is a leading cause of maternal mortality, accounting for almost 35% of maternal deaths. So MMR, maternal mortality ratio in the developing countries, was 240 per 100,000 live births compared to 16 in developed countries. 14 million women suffer from PPH. Globally, incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. In India, approximately 38% of maternal deaths are due to PPH. 25.7% of global deaths take place in India, and 2/3 of these is attributed to PPH. India has an unexpectedly high maternal death rate of around 540 per 100,000 live births. So what is the etiology of postpartum hemorrhage? So basically, it's the most commonest cause is uterine atony. So this is nothing but inability of the uterus to contract, which may lead to continuous bleeding. The next common thing is coagulopathies. So if there is any failure in the clotting factors. The third is uterine trauma. Any injury to the birth canal, rupture, and uterine inversion or lacerations could be the reason for PPH, or it can be because of retention of placenta and clots and an abnormal placenta. So most commonly, it is the atonicity of the uterus which leads to PPH. So how do we, what are the clinical findings? So basically, patient can have abdominal tenderness, a circulatory collapse, increasing abdominal girth, loss of uterine contractions, maternal tachycardia, and continuous vaginal bleeding. So when the blood loss is heavy, the patient can land up in shock. So here in the table, we are telling you few aspects about the degrees of shock. So it can be a compensatory, mild, moderate, or severe. So here, what all clinical findings we notice? When do we call mild? When do we call moderate? When do we call severe? So when the blood loss is between 1000 to 1500 ml, that is around 15 to 25%, then it is mild. If the blood loss is 2000 to 3000 ml, then it is classified as severe. So the blood pressure changes If it is mild, only there is a slight fall in the BP. When it is severe, when the BP profoundly falls to 50 to 70 millimeter mercury, it is called severe. And in severe cases, a patient can have collapse, air hunger, and anuria. So there can be no passage of urine at all. So in mild cases, the patient can just present with weakness, sweating, tachycardia, and in the compensatory phase, they can have palpitations, dizziness, tachycardia, and in the moderate, they can present with restlessness, pallor, and oliguria. So here we don't want to take the patient to the severe degree of shock. So if we recognize and if we give the medication as early as in the compensatory phase, then we will be able to prevent the maternal mortality. Next slide. So diagnosing postpartum hemorrhage, initial evaluation, rapid assessment of patient status, presence of tachycardia and hypertension, assessment of vital signs and blood loss, as I have already mentioned. Then examination at the time of hemorrhage, assessment of the entire genital tract for lacerations, hematomas or signs of uterine rupture, manual examination for retained placental tissue, assessment with bedside ultrasound to check if the uterus is non-contracted, evaluation of uterus to check for uterine inversion. Then laboratory assessment like complete blood count to check hemoglobin, hematocrit and platelets, coagulation studies and assessment of fibrinogen. Next slide. So how do we approach, once we have diagnosed with this, how do we approach to the treat the postpartum hemorrhage? So whenever there is a poor uterine tone, which I said is most commonest, atonicity of uterus is the commonest. What are the clinical findings? So on abdominal palpation, the uterus feels relaxed. It feels boggy and soft. The uterine fundus may be felt above the umbilicus if the uterine cavity is filled with blood and clots. So the investigation, we do a full blood count, coagulation profile, urea electrolytes. If patient is not responsive to fluid and blood replacement, then go for an ultrasound to exclude uterine rupture or intraperitoneal bleeding. So whenever there is atonicity, the first thing is we massage the uterus, we make it taut. So then we start giving uterotonic agents like oxytocins, prostaglandins, ergot alkaloids. Sometimes we need to place a uterine balloon tamponade, and if none of these work, then we go in for stepwise surgical management. If the medical treatment fails, we go for stepwise medical management, and the last resort would be to go in for a obstetric hysterectomy if the bleeding doesn't come under control at all. So that is for poor uterine tone. So the next commonest thing is if the tone of the uterus is good, then we check for the lacerations in the cervix. So there can be a tear or a trauma. So the bleeding from the trauma areas within the genital tract is observed. So we put in a speculum if it is a case of normal delivery. If you have not given an episiotomy, or if there is a extension of episiotomy, or if there is a tear, then this has to be, the outer tear has to be recognized. The inner tear, if there is any bleeding from the mucosal layer, then that also has to be checked. So for this, or sometimes there can be bleeding from the cervix. So what we do, we put in a speculum, go back to the previous slide. Go back to the previous slide. So we put in a speculum, then inspect the entire area to see where the bleeding is occurring. And once the bleeding, you are able to recognize the site of bleeding, then it is very easy, and if you take a stitch, it will come under control. So sometimes there can be a uterine rupture, there can be extension of uterine angles. So these are more common in cesarean section. And sometimes there can be extragenital causes such as subcapsular liver rupture or rupture of ovarian or splenic vessels. So the bleeding can be because of that. So this can be recognized and accordingly it can be managed. So inspection during cesarean section by exteriorizing the uterus becomes very mandatory. Sometimes we'll have to get in a bedside ultrasound to identify the bleeders. And management is mainly repair of the identified genital tract trauma or pelvic arterial embolization. This may be required in case of broad ligament or supralevator hematoma. The next commonest cause for postpartum hemorrhage will be retained tissue, retained placental tissue. So this, in a case of normal delivery, we have to put in the hand inside, do a manual removal of placenta or the retained products of conception. So many a times, if the placenta doesn't come out easily, we have even in a normal delivery, we have taken the patient to OT, given anesthesia, and then under anesthesia, the products of conception have been removed, and in that only then the bleeding will come under control. Or the next commonest is coagulopathy. So what happens in coagulopathy? There can be continuous bleeding even though the uterus is contracted. That time, do a full blood count, do a coagulation profile, do the blood urea, creatinine, and electrolytes, and go for a medical management or surgical management depending upon the condition. The attempts should be made to identify the cause in the women who are bleeding in parallel with resuscitation. So that becomes a very important approach. Next slide, please. Rationale for the development of carbetocin. So now we have a wonder drug, something called as carbetocin, which is available in room temperature, a stable formulation and a convenient vial preparation. So carbetocin has replaced our OT and labor rooms with oxytocin. So oxytocin used to be our most favorite drug, and now carbetocin has actually overtaken the use of oxytocin. So it is used to prevent postpartum hemorrhage and it promotes uterine contraction after childbirth. It's also being it is also being studied for treatment of symptoms related to something called as Prader-Willi syndrome also. So it's a synthetic analog of oxytocin. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. But here, carbetocin being a synthetic analog of oxytocin and it is stable at room temperature, so it has become more easy for us to use this, and maintenance also has been easy. Heat stable formulation of oxytocin is currently not available, but carbetocin has a shelf life of 24 months at 30 degrees and 75% humidity. It avoids need for cold chain storage and logistics, and it is provided in a vial. So these are the advantages of carbetocin over oxytocin, and hence even in remote areas, carbetocin can do wonders. Next slide, please. So use of uterotonic agent, time of administration at the crowning of the baby's head, at the delivery of anterior shoulder, at the end of second stage of labor, following the delivery of placenta. Prophylactic use, prevention of PPH and active management of third stage of labor. Therapeutic use is management of PPH. So what are all the molecules which are available? We have oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Next slide. So carbetocin, it's a next generation drug for PPH management. It's a synthetic long-acting analog of oxytocin. The therapeutic indication is prevention of postpartum hemorrhage due to uterine atony. One vial contains 100 microgram of carbetocin in 1 ml solution for injection. Carbetocin created by several modifications to the oxytocin structure It prolongs half-life and it reduces the enzymatic degradation. Next slide. So coming to some of the clinical efficacies. So there have been a lot of studies which have definitely proved the efficacy of carbetocin. So it has a longer duration of action compared to oxytocin, and it reduces the risk of PPH. It's being studied for its potential to improve obsessive hyperphagia, and it has very less side effects. So one disadvantage of carbetocin is oxytocin. It's used in the induction of labor, but carbetocin cannot. Oxytocin is used in augmentation of labor, but carbetocin does not. But it is not used in the treatment of PPH, but it is used in the prevention of PPH. The half-life of carbetocin is around 40 minutes. Storage, it can be stored in room temperature and it is heat stable. And the uterine contractions within 2 minutes, the sustained uterine contractions is seen within 2 minutes, lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes when it is given IV. When it is given IM, sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 minutes. So I think you can go to the next slide. So the largest clinical trial in the prevention of PPH was the Champion trial. The trial conducted by WHO Department of Reproductive Health and Research. The study design non-inferiority double-blind randomized trial it was to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Approximately 30,000 women across 10 countries were included in the study. And the primary outcomes was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, the proportion of women with blood loss of at least 1000 ml. So this was studied and they found out that the additional requirement of uterotonic agents was very less. Next slide. So the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus when compared to oxytocin. So the blood loss of more than 500 ml or the use of additional uterotonic, the efficacy was around 14.5% with carbetocin and 14.4% with oxytocin. So the conclusion was that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. So it significantly did not differ in the two groups. Then there is a Cochrane review, carbetocin for preventing postpartum hemorrhage. In this Cochrane review data from 11 studies involving 2,635 women were included. The author concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer side effects. So what does the guideline recommend? So we have various guidelines. Society of Obstetricians and Gynec of Canada 2009, Danish Society of Obstetrics and Gynec 2013, Ministry of Health of Russian Federation 2013, Expert Group of Polish Gynecological Society 2013, Chinese Society of Obs and Gynae 2014, Philippine Obstetric Gynae Society 2014, Queensland Maternity and Neonatal Clinical Guidelines Program 2013, Mexican National Center for Health Technology Excellence 2008, and most of all, WHO 2018 recommending body says that only one of the following guidelines for PPH prophylaxis, that is Carbetocin, has done wonders. SOGC Canada 2009 says Carbetocin 100 microgram IV bolus. Then FIGO says one of the recommendations for PPH management is Carbetocin. Germany, Austria, Swiss body, New Zealand, FCOG, France 2015. So all of these have proved that Carbetocin is not inferior to oxytocin, and this was achieved in Champion Trial 2. Next slide. So
Yeah,
I've
madam.
been using I've been using Carbetocin from past 3 years, and definitely it has reduced the use of additional utritonics. So at the most we would have required uterine massage for uterine atony, and with 100 microgram of IV bolus Carbetocin, the uterus contracts very well and it sustains throughout C-section. We have not had I have not had a place wherein I have used extra utritonics.
Oh, and you generally prefer IV route?
Yes,
That's correct. I mean, you must have been using for past 3-4 years, madam.
yes.
Yes,
I've been using from 3 to 4 years, and definitely even the use of oxytocins have reduced.
yeah,
Use of
correct.
what is that?
Prostaglandins.
Prostaglandins.
Yeah,
Prostaglandins sometimes, we still use
correct,
prostaglandins.
correct,
So I still use. At the end, I give 600 microgram of PPH.
correct.
You are comfortable at night,
Yeah, yeah, yeah.
not worried about the bleeding later.
Correct, correct. I
So
mean, this is one condition where you can expect PPH in every patient. You have to be
correct,
prepared. You don't know
correct,
which patient will finally land.
correct,
Yes.
correct.
A few questions, madam.
Yes.
Which patient profile doctors can anticipate a PPH?
So basically, patient with comorbidities like anemia, or if they have blood pressure, obese ladies, these are
Likely
more
to get.
common. Yes,
Anemia could
and
be a major
sometimes, yeah,
anemia could be a major cause in our country, no?
anemia.
For
Yes,
yeah, yeah,
anemia could be a major
major
cause.
cause. Yes. And
So,
even fibroids or diabetes could also, I suppose, affect in some way,
small fibroids will not affect
not
much.
affect.
So if the patient has a huge fibroid, maybe around 6 centimeters, seven
Oh, oh,
centimeters and above, then sometimes, yes, you can anticipate.
correct.
Otherwise, yeah, anemia is the major cause.
Correct. In our country, it could be.
Yes, and uncontrollable hypertension.
Yes, yes, yes.
So that also,
Precipitates.
diabetes per se is we cannot anticipate.
Uh,
If it is under good control, I don't think I have had any issues with GDM patients.
And in case of retained placenta, any experience, madam, you have with carbetocin?
Um, Direct experience, though, I don't have with retained placenta, but I have come across one or two friends of mine who have
Oh,
used it.
okay,
So they say the placenta gets, it readily comes off
okay.
once carbetocin is given, and even in normal deliveries. So we have seen, the moment give carbetocin, the placenta easily comes out.
I
So
suppose
I
the
think in retained
fundus,
placenta, definitely it works.
it
So, and
works.
it does wonders, Carbetocin. Your experience, sir?
I mean, we have got all this experience, in the retained placenta. People have used it and people feel this benefit. Of course, after removal of placenta, because right from fundus, it starts contracting. Na?
Correct,
So that's one.
correct.
And case of RH negative mothers, any experience you have?
RH negative mother, I've been using
Yeah,
Carbetocin,
yeah, yeah. People
and
also
I have not
no
had any
any
issues,
untoward
and
effect. Correct,
yeah,
correct.
yeah,
And anyway, we take precaution with all those anti-D, etc., etc. So nothing.
correct, correct. Antenatal anti-D also we have been giving now.
Yes, yes, yes.
So till today, yeah, no problem with
Okay.
Rh negative mothers also. And I have used Carbetocin for them and I have not had any issues. No retained placenta too.
Good, good.
Mm,
Can a doctor use carbetocin for prevention of PPH if oxytocin? I mean, oxytocin is our textbook brand. All of us use it for labor induction. But can we
correct.
use carbetocin for prevention of PPH?
Yeah, we can
We
definitely
can.
use. No
But,
contraindication.
madam, have you seen any time any ADH related side effect with oxytocin?
Uh, Up to 40 units, whenever
Nothing
we have given,
happens.
we have not seen. Not seen.
A prolonged use can sometimes, yeah,
Maybe prolonged usage,
correct.
but up to 40 units, whatever
Nothing
we have
happens.
used,
Nothing
we have
happens.
not seen any.
In which cases you prefer IV or IM? Or generally you prefer IV?
I usually prefer IV route.
IV.
Yeah, less painful for the patient and
Yeah. And immediate
action
action
is
also.
faster.
Immediate,
Yeah,
correct.
action is fast.
Any deadly side effect with carbetocin?
As of now, I have not seen any
God bless. You
deadly
should never have. You
complication.
should never have.
Yes,
This PPH is a topic, wonderful topic to discuss, but we always feel no doctor should ever get it.
correct, correct.
If a patient is not responding
The
adequately,
nightmare is when there is a placenta previa
my God,
of different degrees.
madam,
So that is the only nightmare. So one case I had of placenta previa. So we used carbetocin, we used oxytocin, we
oh
used
yes,
everything. We did stepwise devascularization. Nothing worked out. Bleeding did not stop. And maybe in this 3 years, I have done one obstetric hysterectomy.
oh
That lady landed up with obstetric hysterectomy.
my God.
So it didn't stop at all for anything. It didn't budge at all.
Yes, there will be some patients who will not respond to anything. That will always happen.
Correct.
In fact, I mean, I always share my experience during my houseman days. We had only oxytocin and methyl ergometry. And
Correct.
when we had PPH, the whole hospital would be there in that unit.
I
I mean, you
know.
can
I
imagine
know.
what it ought to
I
be
know.
ready. Yes,
Even
yes,
I
yes.
remember during my student days,
Ah,
we used to get scared. We used
yeah,
to
correct.
get scared if it is a PPH, and the entire hospital used to be there.
Yeah, yeah.
Correct.
If patient doesn't respond to a carbetocin, which will happen sometimes, which other uterotonics you use in
I
your
have
order or
used,
preference?
yeah, if there is no contraindication for methergine, I've
Methyl.
used methergine. I have
Yeah,
used intramyometrial
prostaglandins.
prostaglandins.
Yes.
And yeah, with that, it can come under control.
You must,
Sometimes used oxytocins also.
yes, yes.
So,
With this prostaglandin, sometimes that vomiting वगैरह happens. Na?
correct.
Yeah.
Correct.
And in their
Whenever
golden,
I give intramyometrial, the
yeah,
vomiting is not much.
much less.
So,
Correct.
I usually prefer a intramyometrial route.
Biometric. I mean, you've already answered this. Should carbetocin be kept as a reserve drug or should we use a first line?
I think it should be used as a first line.
Correct, correct. I mean, looking at the advantage and especially on a single
Yeah.
dose, you don't
Single
require
dose.
yeah, storage conditions are favorable. In
Yes,
our country, in the interiors, this could be a major advantage more than anything.
correct.
Is it true that someone said if carbetocin doesn't affect this question was asked to us by one doctor. Other doctors, other drugs don't work. Is it true? I mean, we don't feel it is true, but then
Nothing like that.
yes, all
So
have got
even
different mode of
even
action.
if carbetocin fails, and I think couple of cases we have used oxytocin, it
If
has worked.
yeah, yeah, yeah.
It has worked. Maybe I think the mechanism of action is only different.
Different
So I
now,
think
so it will work.
it should
Yes.
not come in interaction at all.
In your hospital, madam, role of an anesthetist vis-a-vis gynecologist for choosing a drug for PPH?
Yeah, wherever I work, anesthetists also are happy with carbetocin.
Carbetocin, that's
So
good.
they can just give one
One
IV
shot.
dose and they can be, rest assured that
Correct.
the surgery is going smoothly.
I mean, it's the best thing
So
available
many a
today
times
as
they
of now.
ask, everything is okay now, doc, and they go to the next case, to the next room.
Correct.
With carbetocin, yes.
It's correct. Just to conclude, madam, your take-home message for the audience.
So, thinking over the advantages of carbetocin, I think carbetocin does wonders in our routine practice, and it should be there in every labor room and in every OT. And the major advantage of carbetocin is single dose, and it can be stored in room temperature.
Correct.
So the potency of oxytocin, by the time you remove from the fridge and then
Oh,
you get
yes, yes.
it, so many a times, even for labor induction, when we give oxytocins, we have told, change the drug because there is no action seen at all.
Yes, correct, correct.
So probably the storage plays a very good,
Yeah,
very
and
big role.
transport, how do they do transport? We don't, it's not in our control. There is
Correct,
power outage everywhere. Even in big
correct,
cities, there's power outage.
correct.
Yeah,
At a time, if three, four labor cases are going on, and if
yeah,
everybody is busy, by the
correct.
time you get the vial to the patient whom you are doing,
Yes,
definitely it would have lost its potency to a certain.
potency. Correct, correct.
So I think carbetocin in that way is a
Of
very good
course.
drug.
Madam, thank you very much, madam, for sharing your experience.
Yeah.
It was a lovely session, your insights into the product, the confidence that you gave to the audience. I mean, this is exactly what they want. There are papers, there are studies, but the confidence of our own doctors will help them. And I'm
Yes.
sure this will help them. Thank you so much.
Yeah.
Thanks,
Thank you. Thank you, sir.
marketing team. Thanks, IT team. Thanks, Nagadevi. Thanks, Bivas, for making this possible. Thank you, sales team of
Yeah.
Eatable. Thank you
Yeah.
so much, madam. And we can sign off, madam. Thank you.
Thank you, Hetero Healthcare, for
Thank
giving
you.
this opportunity.
Thanks so much, madam. Thank you. We can sign off, madam. Thank you.
Yes, yes.
Thanks,
Thank you,
Bivas.
sir. Thank
Thank
you so
you.
much.